Ureteric stone depends on factors such as the stone's size, location, associated symptoms, and the degree of obstruction or renal impairment. Here is a comprehensive approach. Initial assessment. 1. History and physical examination. Assess for pain, hematuria, signs of infection, fever, chills, or urinary retention. Evaluate for previous stone disease or family history. 2. Imaging studies. Non-contrast CT, NCCT scan, gold standard for diagnosing size, location, and density of the stone. Ultrasound, useful in pregnancy or to assess hydronephrosis. X-ray KB helps in identifying radio-opaque stones. Intravenous urography, IVU, to assess functional obstruction, rarely used due to CT availability. 3. Laboratory tests. Complete blood count, CBC, serum creatinine, and electrolytes. Urinalysis, check for hematuria and infection. Urine culture, if infection is suspected. Management options. 1. Conservative management. Suitable for stones 10 millimeters in size without severe obstruction, infection, or renal impairment. Medical expulsive therapy, EMET, alpha blockers, e.g. tamsulosin to relax ureteral smooth muscle. Pain relief, NSAIDs, e.g. diclofenac. Hydration, encourage oral fluid intake to promote stone passage. Monitoring, follow-up imaging in 2 to 4 weeks to confirm stone passage or resolution of hydronephrosis. 2. Surgical interventional management. Required for stones 10 millimeters or smaller stones not responding to conservative measures, severe hydronephrosis or renal impairment, associated urinary tract infection, UTI, or sepsis, persistent pain or obstruction. A. Extracorporeal shockwave lithotripsy, ESWL, best for stones 2 centimeters and not dense, 1,000 Hounsfield units on CT, non-invasive but less effective for impacted stones in the upper ureter. B. Ureteroscopy, URS, flexible or semi-rigid ureteroscopy with laser lithotripsy, holmium, YAG laser, useful for larger or impacted stones, requires ureteral stent placement post-procedure to alleviate swelling and prevent obstruction. C. Percutaneous nephrolithotomy, PCNL, indicated for large stones 2 centimeters or when ESWURS fails. Can be combined with ureteroscopy in some cases. Open laparoscopic ureterolithotomy, rarely used, reserved for very large impacted stones or when other modalities are not feasible. E. Emergency management. If infection sepsis is present, prompt ureteral stenting or percutaneous nephrostomy to decompress the kidney. Delay definitive stone removal until infection resolves. Post-treatment care, stone analysis, to determine composition and guide preventive measures. Metabolic evaluation. In recurrent stone formers, e.g. 24-hour urine collection, serum calcium, uric acid. Lifestyle and dietary advice. Increase fluid intake to maintain 2 liters per day urine output. Dietary modifications based on stone type, e.g. low oxalate, low sodium diet. Early and appropriate management minimizes complications such as renal damage or recurrent infections. Regular follow-ups are essential for monitoring and preventing recurrence.